Good afternoon. My name is Bernadette Thomas. I am a nephrologist. I work part-time in private practice, and the other portion of my time I'm a clinical assistant professor in the Department of Global Health at the University of Washington in Seattle, Washington. It's a pleasure to be here today. It's an honor to get to speak at the 25th anniversary, so thank you for the invitation. I'm going to tell you that I have no disclosures, and I'm going to take this time and this opportunity to tell you a story. And the story is how I transitioned from being a nephrology fellow to a nephrologist who's had the opportunity to explore the challenges and needs for renal replacement therapy in regions of the world that are considering developing regions of the world, and how research, specifically clinical epidemiological research, played a critical role in figuring out exactly how to get things done and also whether to get things done. So my talk is going to be the story of sort of an evolution of thought, and we'll conclude with where we are today with our attempts at addressing such needs. So in the kind introduction, I am a researcher that's been involved in the global burden of disease study. Just to give you a little bit of a background on what that is, it's a study that's sort of flagshipped by the World Health Organization, but is accomplished in conjunction with universities from all over the world. But the flagship university that really organizes and executes it is the University of Washington. The Institute for Health Metrics and Evaluation, the IHME, is an institute within the Global Health Department at the University of Washington. The institute is funded by one multi-million-dollar Gates grant, and one of its major objectives is to conduct the global burden of disease study. It was first released in 1990, and then it's released in serial updates. It's always published in The Lancet. And the goal of the study is to quantify and list the leading causes of death and injury for countries throughout the world. The most recent edition that's published is GBD 2013. That was published in the Lancet about 6 or 7 months ago, and we are at the last stages of completing the GBD 2015 analysis. At this time, over about 2 decades of evolution and process in increasing our access to data, our collaborators, and our methods, we now describe the leading causes of injury and illness for 188 countries throughout the world over 6 time periods, starting with 1990 and now ending with 2015. What I have up here is one of the images that we create in order to make that amount of data conceptually digestible. The metric of preference that we use in order to describe our results is the DALY, the Disability Adjusted Life Year. You can see that up there. What the DALY describes is it's a metric which comprises life loss, but also health loss to a condition. For example, if you have a process such as Ebola, where if you get it, it's highly lethal, but you're not sick for a long period of time, Ebola has a very high mortality rate. Whereas if you have another condition such as diabetes mellitus, it's not going to kill you in a week to 2 weeks, but if you suffer with the condition for a long length of time, maybe to 20 to 30 years, it will cause a lot of secondary health effects which dramatically reduce your quality of life. So the DALY is a combined metric which combines mortality, but also morbidity to a condition. So this is a map that we create, and I've played with the settings. This is an interactive tool, so you can go online and choose any world region, the global level, or a country of interest if you'd like to experiment with these results for yourself. But this is a map that illustrates the region Southeast Asia. And the time period that I've chosen is 1990. And before you get lost in all of the tiny data, I want to draw your attention to the 3 colors. Blue indicates a non-communicable disease. Red indicates a communicable disease, and green is injury or war. For the region of Southeast Asia in 1990, when considering the major contributors to disability-adjusted life years for that region at that time point, you can see that the majority of this map is red. So infectious diseases were the things that were really crippling society at that time, when you consider all ages, both genders. Let's fast forward to 2013. So these are our most recent published results. Southeast Asia, disability-adjusted life years, different year. What do you notice? A lot of blue. Now you can actually read the blue. See a few things pop out. Diabetes, ischemic heart disease, stroke, COPD. And what has ratioed down is the degree of red and also the degree of green. That's actually, when I've seen a lot of these maps for a lot of countries, it's still a significant amount of green. Road injury, when we think about developing countries. So this is telling the story of what we all kind of know, in that throughout the past 20 years in the world, there's been a huge epidemiological transition from large portions of the world. The developing world has the majority of the world's population within it, and infectious diseases are no longer the number one killers, but also no longer the number one causes of health loss, not just life loss, but health loss. They're starting to exhibit a disease profile very similar to where developed countries were 20 years ago. So to speak specifically about Cambodia, in thinking about a country and whether to get, if you're ever invited to champion a cause, if somebody hands you a country and says, we need you to start PD in this country. I've given this talk a lot, and one of the main questions I've gotten without fail about the question of Cambodia is, why Cambodia? And it's a fair question. When you think of a country that has no access to renal replacement therapy, before you get to the hows of starting a program to increase renal replacement therapy access, there's an important question of should you? Is it the main priority of the country in terms of where you're going to allocate limited health expenditure? So who is Cambodia? I think in order to understand a country, you have to think a little bit beyond the health, to think about just the health of the country in general. It's a country in 2014 that had a population of about 15 million people. And in terms of financial stats, their GDP, their gross domestic product, about $16.7 billion. And I thought, well, how do we orient that? I don't know if we're a crowd that speaks GDP every day. I'm not. So I popped up Canada's GDP, which is a very, very, very impressive $1.7 trillion. Just to give you an idea of a comparison of how much financial activity, how productive is that country in a year. The per capita income in Cambodia is about $2,000 US a year. A WHO speak way of thinking about health for a country are life expectancy and also the future population of the country. How are the kids doing who are going to form the population structure 20 years down the line? The gender stratified life expectancy is 64 years for women, 61 for men. It's consistent to the global trends that show that women have a slightly higher life expectancy. I've often heard the awful joke of how women have the advantage of living slightly longer than men, but they also have a higher likelihood of developing Alzheimer's, so they're not going to remember that they lived slightly longer. Sorry. Just to put those life year expectancies into perspective, when we calculate disability-adjusted life years, we basically have to compare when you die, how much life, when you count mortality to something that's fatal, you basically count mortality, did you die or not? But when you count years of lost life to society, which is another health metric, if somebody is experiencing an epidemic that wipes a large majority of the 20-year-old population out versus the 80-year-old population out, it's a lot more life lost to society. And in order to map that out, we have to have a standard, gold standard life expectancy, and that always comes out of Japan, where they live on average the longest. So 64 for women, 61 for men is pretty far down from the optimal life expectancy, but the lowest rates were a lot of sub-Saharan African countries where the life expectancies were in the high 40s to low 50s for some countries. The under 5 mortality, 45 per 1,000 live births. Again, to compare it to Canada, with a very impressive 5 for 1,000 live births. So just to give us a sense of who Cambodia is as a country in terms of its general health. It's definitely not a country in terms of the developing countries of the world that is struggling the most, but has a little bit of room to go in regards to matching the standards for middle income or developed countries. So kidney disease in Cambodia. Before introducing the data on this slide, I'd like to give you a little bit of background about how I specifically got that invitation. Can you come to Cambodia and solve this problem? At the University of Washington, there's an internist named James Legerfo. He was the medical director of our Level 1 Trauma Center and has been using the golden portion of his career. I don't think he'd mind me describing it that way. About 10 years of his life, he's been contributing to traveling to Cambodia to specifically develop their medical education infrastructure. What he'd noticed was that the main training hospital for physicians is in the capital, Phnom Penh, and basically students went through their training, and it was very rote academic training. They never laid hands on a patient. They graduated, and they were doctors. And that was when they started seeing patients. And he thought, well, wait a minute, you have to have some sort of mentoring, shadowing. I must learn this from you. And so he's spent 10 years transitioning their training structure to one that's more similar to the structures that we're accustomed to. But two important things happened in that 10-year span of time for him. One is that the Cambodian administration and physicians at Calmette Hospital, which is the hospital associated with the medical school, it's the top hospital in Cambodia, fell in love with him because they realized he was somebody whose heart was completely invested in improving the way things happened. And he knew that if you started with the students and improved the training for the future doctors, you would affect the care quality for the country. The second thing that happened was, as an internist, he observed that the country has no renal replacement therapy at all. They have one hemodialysis unit. It's at Calmette Hospital. They have about 20 machines. They service 100 patients. It's $45 a treatment, but if you want to scale down from the bicarbonate bath to something less fancy like acetate, you can trim down the cost to about $30 a treatment. And patients are getting about 2 treatments a week in order to afford this. There's a governor in northern Cambodia that was driving down to Phnom Penh 4 hours each way, twice a week to get dialysis. It's the only renal replacement therapy. So he, James Legerfo's longtime book club partner, Michael Kelly, one of the most loved nephrologists in Seattle, he petitioned Mike Kelly to come to Cambodia and said, we need nephrology activity within this country. Mike finally went, looked around, and made one statement: you need PD. And then he told him that there was a fellow at the time that was interested in global health, and then I was invited to go with Jim Legerfo to do a site visit to figure out how to implement peritoneal dialysis. At the time, I had already been involved with the Global Burden of Disease study to figure out how to implement chronic kidney disease as one of the diseases that they quantify so that it would show up on that fancy map. And that took 5 years worth of effort, but it took collaboration with the ISN, the ISPD, Sustainable Kidney Foundation, in order to make enough connections to get data from all over the world so that 188 countries would have their data represented in our study. In the process of doing that, once I got to Cambodia and realized, oh, they need PD, I just reached out to those organizations and said, this is where I am, and I need your help. And John Feely, who was the president of ISN at the time, emailed me back in 5 minutes. So here's where we sidetrack from that story to discuss how research fits into this, this whole structure. When going to Cambodia and figuring out whether to start a dialysis program, the first question that comes to mind is, who is going to receive this? Because we already know who's receiving it now. People who can afford a $45 treatment, 2 treatment a week, hemodialysis session. That's who's getting it now, and it's about 100 people. How much of a burden is there? And once we know the burden, how do we address that burden so we're reaching more people? So at the time when I started, I did a quick lit review, and there was nothing I could find that was published on kidney disease in Cambodia. So the burden was a huge unknown. But what had been done was a step survey by the government in Cambodia using the WHO criteria. It was conducted in 2010 to determine what the burden of non-communicable diseases were in Cambodia. So this was an excellent sign that this study had even been done, because it meant that when we think about who is the country, if you have a country that's struggling with a high degree of deaths, a high degree of the ratio of live births in terms of mortality of the under 5 population, if you don't have immunization campaigns, if you don't have clean water, those are the things that you have to do to rapidly reduce death. And those are the financial priorities for the country before you start talking about non-communicable diseases. You have to have immunization campaigns for children before you set up dialysis. Not having dialysis is not a good enough reason to set up dialysis. But if you have a country that's executing a step survey to quantify and start to think about how much non-communicable disease do we have in our country and how is it affecting us, it's a country that's already starting to think about non-communicable disease burden. So this was an excellent sign. It was a wonderfully conducted study. It abided by the criteria that the WHO had spelled out. There was stratified sampling so that it was population representative. And what they found was that about 11.2% of the population had either a new or previously diagnosed condition of hypertension, defined as a systolic blood pressure greater than 140 millimeters of mercury. And they also found that you were more likely to be male and you were more likely to live in an urban environment if you had hypertension. And in evaluating impaired fasting glucose or diabetes, they found similarly that you were more likely to be male and more likely to be in an urban setting if you had either impaired fasting glucose or diabetes. The problem with the WHO recommendations for the STEP survey is that though they collect the creatinine data, they don't analyze it. So there was no burden of kidney disease quantified. So it helped, but it didn't answer the question. So in trying to scratch the surface of how much kidney disease is there in this country before we figure out whether or if anything to do about it, I, in partnership with Dr. Malhotra, spoke here yesterday, and James Legerfo, who I mentioned and is the senior author of this paper, conducted this study. So the population that serves as the reference for this study are Cambodians that live in rural settings that have no access to screening or treatment for chronic disease. Maurits van Pelt is an old Médecins Sans Frontières guy who was in Cambodia about 25 years ago with an MSF mission. After the mission was over, the team left, but he decided to stay. And he set up a screening, basically a screening project where he went into the urban area, the rural areas, screened the population for high blood pressure and diabetes, and treats them. He's developed this program single-handedly. When I met Maurits, he asked me so many kidney questions. I was so impressed at how a nephrologist of his caliber was working single-handedly to accomplish what he was doing and was collecting data, full demographics, full follow-up data. He was collecting lab work, and he had vetted the labs until everything matched standards as good as the university that I worked with. We had a full discussion about kidney disease, about how Cambodia 30 years ago had had a war, the portion of the population had been wiped out. He wanted to know if the survivors had some sort of genetic predisposition for diabetes and hypertension, because maybe that was the reason they survived famine. After the 3 hours conversation, I found out that Maurits was not a nephrologist. He was not even a physician, he's an economist. But he spends a lot of alone time and he reads a lot and was quoting journal articles to me. So he gave me access to the data that he collected. It was about 2,000 participants in his study. And we were able to document basically the burden of CKD categories, gender stratified, and at 2 years follow-up, what was the rate of progression of kidney disease after they were treated in Marit's project. And we presented these data, and people have been impressed with basically the lack of progression of kidney disease based on the treatments that he's been recommending. And not only were we impressed, but the government in Cambodia was so impressed they're adopting his program to be spread to a nationwide program. These are the first data to be published from Cambodia about the burden of kidney disease. The credit goes more to Marit's than to our team. So when you take the STEP survey, which gives us a guesstimate at the prevalence of diabetes and hypertension, and you take Marit's data, which indicates the CKD category burden for a population that is diabetic and hypertensive, you can do some very rough math to figure out, okay, well, how many people with CKD are there? And so we estimated there are about 100,000 patients that have some level of CKD within Cambodia at the time. What's very heartening is that Cambodia is repeating the STEP survey now, and I'm going to appeal to their government to see if they'll, with a small, if we can find a small grant to support it, analyze the data so that we can have actually a nationally representative analysis of their data to publish on kidney estimates. So where does that take us? It seemed like there was a significant need, and the country was at a point where they were able to consider, if we have a burden of kidney disease and a portion of that kidney disease population needs renal replacement therapy and nobody is getting access to it, what are our options? Michael Kelly had recommended, I think you need peritoneal dialysis. And when I reached out to the international community, I found that the ISN, in conjunction with multiple partners, had been supporting projects such as this in similar locations, places around the world, some in Asia, some in Africa, that were ready or interested to have a PD program developed. If there was interest on the ground floor of the country and an academic center located elsewhere, like the University of Washington, that would form a mutual commitment to developing the program and making it happen. And so I applied for Cambodia to be considered to be one of those sites where we would start a PD program for treatment of acute kidney injury at Calmette Hospital. We had a lot of benefits to pitching the idea to ISN, and one is that Calmette has nephrologists. They've been treating patients with hemodialysis. So a lot of that, infrastructure was already there. What we were arguing for was a transition. And it's not just a transition to extend renal replacement therapy access to people who didn't have it, but even for the people that could afford it, people traveling from all over the country because they have to get to this center. This is something that could be a game changer in terms of quality of life for everybody. So why did we choose PD? I think I'm preaching to the choir, but these are the points that we outlined. PD doesn't require complex machinery, so it's elegant in its simplicity for what it can provide to the patient. It reduces the need for trained technicians and mechanics, and so there are potential cost savings in that. A minimal requirement for technical support. The therapy is simple enough that the governor in the north of Cambodia doesn't have to travel, but also a patient can be trained and take it to home and provide care to themselves at home, so it gives a certain sense of autonomy to the patient. There's a lack of dependence on electricity, water purification, and patient transportation. It saves cost for the patient, but electricity and water purification systems are, in developing regions such as Cambodia and in a lot of other places, maybe the thing that determines that you will not be able to go forward with a hemodialysis unit. And so these are ways forward for resource-limited settings such as Cambodia. Potential cost savings. So when I reached Cambodia for my first site visit, Jim Legerfo set up a meeting with the entire medical board of Calmette, and we met in their beautiful boardroom, and it was about 10 people on their side of the table and Jim and I on the other side. And we basically gave them a chance to ask us questions about peritoneal dialysis and why they should consider this when they already have a hemodialysis unit. It was 3 hours of constant questions. And the questions revolved around, how much is this going to cost? We've heard about the risk of infection. Why would we want to subject our patients to infection? What happens if the modality fails? And so I answered the questions as best I could, and then went to the literature and found out that how to set up a PD program in resource-limited settings is not something that's well described in the literature. The most intriguing thing is the answers I found to the question of cost. Cost is not a hard and fast answer for regions such as this. There are a lot of studies, and I think that they're accurate, that indicate that it can be more expensive to provide PD in situations like this rather than hemodialysis. And it sounds counterintuitive, because you think about having a hemodialysis suite, the electricity, the water purification, the technicians, the trained staff, that sounds expensive. So how could peritoneal dialysis possibly be more expensive? And the reason, after 3 to 4 years of dealing with this issue and having these discussions, the one answer that we found is that when you have to get fluids from somewhere else and ship them in, something happens at the border. And you have to exchange a certain amount of money in order to get those fluids in. And it is enough money that it makes PD not be cost effective. So we couldn't answer the question of how much this is going to cost. But for the pilot project, we didn't have to, because the application was accepted from the ISN and ISPD for us to be an AKI center. And so what that enabled us to do was to obtain training for one nephrologist and one hemodialysis nurse from Calmette Hospital to travel to Thailand, where for 3 months they were trained on how to initiate and maintain a patient on peritoneal dialysis. At the same time, Sustainable Kidney Foundation made a donation of 2 years' worth of PD supplies, fluid and catheters, to the project, and we would basically use the fluid to treat any patient with acute kidney injury within that 2-year period of time. The agreement was that in that 2-year period of time, the hospital had to make a plan for how to make the program financially sustainable moving forward. So it gave them 2 years to see, okay, what's happening, get a gauge of usage of materials, develop a budget, and figure out a way forward after the 2 years. The Sustainable Kidney Foundation typically supports acute kidney injury project development for acute kidney injury treatment for patients in resource-limited settings who are children. Because when you think about, we have limited funds, limited resources, when are you going to get the most bang for your buck in a resource-limited setting? It's always when you save the lives of children with acute kidney injury, because they're more likely to recover full renal function, because hopefully they were pretty much healthy before malaria hit or before dengue fever hit. And then you've saved, maybe 50 life years in that one person. So they stretched their agreement by allowing us to start this AKI program for children and adults. So our nephrologist and nurse traveled to Thailand. They went back. The hospital agreed that they would have to figure out a way to get the fluids from the Thailand border to their hospital. And then we would let them start, and all of that happened. They sent me a picture in an email of all of the PD supplies hitting their hospital, and I printed the picture out and hung it in my office. And I think some people have pictures of their kids, and I have these like PD bags. But it was just, it meant that much when we had gotten from the conceptual to that point, and that the hospital trusted us enough to allow us to try this pilot program. And the one thing that the hospital was concerned about was PD catheter insertion. They didn't get to see a lot of catheters inserted in the 3 months that the nephrologist and nurse were trained. And so the ISN has a PD catheter insertion video. And the neurosurgeon at Calmette Hospital watched the video, and he said, yeah, I think I can do this. And so we just kind of crossed our fingers. And months went by, and then I got an email and said, hello, Dr. Thomas. Yes, we are now in the process of providing PD to our first patient. End of email. And the emotions around that. This was their first patient, young guy, 31, came to the hospital, didn't feel well, wasn't peeing. So they took a history, and he was describing symptoms for a week that was largely suggestive to the physicians at the hospital of the flu. In taking the history, they also determined that he was taking huge amounts of some medication to treat symptoms of the flu. And they told me that they thought that the medication included an NSAID, so they think he might have boxed his kidneys. He was otherwise pretty stable, blood pressure okay, he was okay on the medical ward, didn't have to go to the ICU, and they started PD on him. And a month later, I kept emailing and they wouldn't reply. And a month later, I emailed and said, "How is your patient doing?" And they said, "Oh, he's fine." And in prompting for further details, they informed that they started peritoneal dialysis on the 1st. They stopped it on the 15th. They performed 4 to 5 exchanges a day. The number of exchanges was determined based on who was on staff, not what was happening with the patient, but these are the realities. 1.5% dextrose solution was used. He regained full recovery of his renal function and left the hospital. But they let him leave the hospital with the catheter in. And so Fred Finkelstein and Jim Legerfo freaked out when they heard that. And so then I sent more emails. But I think they made a good decision because they asked him to come back to clinic 2 weeks later. And I think they thought if he got into trouble, he still had the catheter. So I think it was pretty smart. So he came back 2 weeks later. They removed the catheter in office, and he's just had full recovery of renal function. We couldn't have asked for a better start and a better experience because this case provided to the hospital 2 things. It provided them with an understanding that this worked, as well as hemodialysis, and that it could work without complications, and that they could work as a team to get this done because it required nurses, the nephrologist, and the urosurgeon. So in 2 years' time after that start, they had 2 more patients who were identical to the first, young people. Something acute happened. They received peritoneal dialysis, and they went home with full recovery of renal function. So this was just sort of the ideal start to this program. So there were a whole host of positives to the program, but I'd say one very powerful negative. And the positives were that the hospital had huge reservations, but trusted us enough to start. That we actually got the supplies to Cambodia, but that Cambodia accepted the responsibility for getting them from Thailand to Cambodia. That we had surgical oversight of the catheter implantation was a huge blessing. We had successful delivery of acute PD, and we didn't have any negative effects. And I kept stressing to the hospital, complications are important, because if you're testing an infrastructure, you not only want to know whether you can provide PD, but can you handle the complications, which are a very real part of providing PD. So detecting and addressing a complication is a part of systems evaluation. But I'm glad that we didn't have to test that part of the system at the very beginning of our experience. We had no negative effects and, a full recovery of renal function. The negative is that we only had 3 patients. So then I conducted an exploratory site visit this past September to figure out why that happened. So here's a picture. You can see Jim Legerfo. He's the tallest one in the group. And somebody lovingly teased him that this is the first time they saw a picture of him where he was the tallest one in the group. And to Jim's right is myself, and these are all of the medical students that he worked so hard to make sure that they had direct physician training before graduating. So I performed a site visit to figure out what happened, and I found 3 answers to the question of why 3 patients. And before I give you the answers, I just want to preface that this AKI program was started with the support of ISN, SKF, ISPD, and when reaching out to Fred Finkelstein, who is one of my mentors, one of my beloved mentors, and the touchstone for all of those organizations getting these projects started, he'd shared with me over a year, we're having this problem everywhere. We're having this problem in Africa, we're having this problem in Asia, in all of the regions where we're setting up these AKI projects. Where are the patients? And the hot hypothesis at the time was that AKI was happening in home or in the rural settings, and these patients were not getting to the hospital. So we were setting up these programs at the place where we're not seeing the AKI burden. So that's what we were thinking. And so then I went to try to find out if that was the truth. And what I found out was that one of the complications was that our nephrologist traveled back to Belgium, where he'd been trained as a nephrologist for transplantation training for about 4 months of the 2 years. So the project was basically on hold when he was gone. The second issue was that patients that went to the intensive care unit who endured AKI were immediately started on hemodialysis by the intensivists, and the nephrologists were not even aware of the patients. And so there was no chance to even intervene, but hemodialysis may have been the right choice in those settings, but the nephrologists were never involved in that dialogue. And then the third was that when there was a patient on the general medical ward that fulfilled the criteria for evaluation for receiving PD for acute kidney injury, they were given the choice between hemo, which they'd have to pay for, and PD, which was free. And a majority of the time, they chose hemo. And I wonder exactly how the phrasing of that conversation occurred. So basically, the 3 patients that received PD with full renal recovery were patients in the general medical ward who presented within the 2 years' time, who were presented with the option of receiving hemo and PD and chose PD. So going back to how research dovetails with these types of efforts, the question I have in my head at this point is, how much AKI is this hospital seeing? Who are these patients in the ICU? Who are these patients in the general medical ward? What's causing the acute kidney injury? How do I make an argument to go forward with this project? We've successfully treated 3 patients. We're at the end of our 2 years. And so I had an idea for an AKI incidence study, which could be conducted at Calmette, at another hospital about a mile away from Calmette that services a poorer portion of the population. And I've also made a connection with a rural hospital in another province up north, where we would perform an AKI incidence study, where we would basically document the patients over a set period of time that had developed AKI using the KDIGO definitions of either serum creatinine or urine output, and classify demographically who are they, what were the major causes, what was the mortality rate, who recovered. And this is information that we need for a majority of the developing and middle-income world regions. The problem was getting time to actually get this done. Then I met an intrepid student that just finished a master's degree at Boston University who is going to medical school in the fall and got a small scholarship to conduct a global health research effort. And somebody put the 2 of us together, and we applied for funding for this study through her scholarship. She just received it, and she's going to be going over the summer to conduct this AKI study at Calmette and the Russian hospital. It's highly publishable because these types of data are just very rare right now, but they will directly address the questions that we have of how to move forward and who will we help. So expansion of this PD program at Calmette, in interfacing with ISN, ISPD, all of the people that have supported us, interfacing with the hospital, and in discussing it all, everybody's really happy with what's happened. We would have loved for it to have been 30 patients, but we're trying to figure out how to move forward to get those kinds of numbers, how to develop a sustainable program. But what we have is a hospital that now trusts in this modality, wants to move forward, and is aware of the limitations that resulted in such a small N. So where we're at right now is we've made a decision that we're going to invest in training 2 more nephrologists so we can increase the ability of the program. One of our earliest supporters of this program at Calmette Hospital has now been made the medical director. And so he personally promised that he is going to interface with the ICU to ensure that our nephrologists get first crack at helping with the decision about hemo versus PD. We're going to investigate more local resources for PD fluids to address the cost issue, conduct our AKI incidence study, and appeal to the government to add PD fluids to their formulary so that if we can make progress with producing fluids in country. That is the cheapest way to develop basically a high capacity program. So the dream. The dream is to create a PD center of excellence in Calmette Hospital, where physicians from hospitals in the surrounding regions can travel to Calmette to learn how to perform PD, because I've been to some of these hospitals, and Fred Finkelstein has come with me and we've performed site visits together. They have great doctors, they have ICUs, they have vents, but if the patient develops anuric renal failure, they're dead. And so if those physicians can come to Calmette and learn how to perform PD, they can start up their own programs with the support of the nephrologists that have gained so much experience at Calmette, and this can be a nationally run program, which is the way to create sustainability. It shouldn't be the nephrologists at the University of Washington with the answers. It should and can be the nephrologists at Calmette Hospital. So in summary, the problem was identified by James Lagerfo. This country doesn't have renal replacement therapy. The burden of how much kidney disease is in a country was suspected, but we're working towards determining the actuals. We now at least have some data. We also have guesstimates within the Global Burden of Disease study. But if our attempts to analyze the data from the current STEPS survey are successful, we'll have a lot higher quality information about prevalence, who, and where. There are certainly treatment challenges that exist, but I think that in order to gain the success that we need, it's really going to revolve around high-quality study to classify what's happening, but also how much it's going to cost to address these issues, which are going to be the main questions for any other country that wants to do what's happening here. And the ultimate goal is program expansion, but my ultimate dream is that once we have something functional and running, we're able to execute high-quality studies to document what happened, how much it cost, and how, if we're able to produce the supplies in country, which is really the game changer in regards to cost, how steps can be kind of laid out so that another country doesn't have to start from the ground with figuring out how to do this, but can take this experience and move forward so that it's capacity building on an international stage instead of just at the country level. So I just want to thank the conference planners for this kind invitation to share some of our experiences, which is it's very much been a labor of love, but a team effort of a lot of organizations and universities, as are listed. James Lagerfo and Fred Finkelstein for having the vision, and to Calmette Hospital in Soviet Khmer for being brave enough to move forward with this for the sake of doing something for their country. And I'd be very happy to answer any questions. Thank you.
Thanks. Great way to end our meeting. It's a wonderful talk, and thank you very much. I have a question and then maybe a comment. In places like Ukraine, for example, there's a very low penetrance of PD. Part of the reason being is that labor is cheap, very cheap. And in fact, they find that actually hemo is cheaper than doing PD. So, and I wonder if that's was the same thing in Cambodia, that the labor cost was a big detriment to having a PD program. The other question that I have is why did you choose AKI and not choose to take those 100 patients who are on hemo, transition them to CAPD, and decrease their travel time, et cetera? Because 3 patients doesn't give you really a lot of go.
Yeah, that's a great point and a great question. The concept of cost in regards to modality is so complicated, and I don't think PD or hemo are always the right answer. It's very situation dependent. Specifically in regards to your question about why AKI, the structure of the program, the time frame of 2 years, and the supplies, that was all provided through the SKF and the ISPD and Saving Young Lives. So we had to work within the guidelines of how they set up these projects. And the guidelines were really supposed to be for children, and they stretched that for our sake. but the supplies were supposed to be used to treat acute kidney injury, mainly because the supplies are considered a limited resource. And you could treat 3 people for the rest of their adult life, or you could save 50 acute kidney injury lives. So when you do the math in terms of prevention of years of life lost, it always came out on the side of AKI treatment. And since that was how the program that accepted us as another site worked, we had to work within those confines, which I felt were very logical. Beginning the project, we had no idea of how much volume we'd get. And, they could have been just turning over patients and doing 3 cases a week. We had no idea until we started what we were going to see. And that's another point to where the data before project would have been helpful. But when it was so slow going, I was starting to beg people, can't we just let the governor, that guy that's driving, because he's the guy we need to start on PD. Because if he falls in love with it, then it gives us a great advocate and, please. And, we'd made an agreement and we had to respect and honor the agreement. But we were also concerned because the supplies would expire and then no one would benefit from them. So, at the end of the day, I think we have enough leverage by proving that nobody died or had a negative event on the PD that the hospital trusted enough. I think we can now start to safely dialogue about chronic and acute, but that was the reason that we had to stick with acute for that time being.